Welcome to the ESOL Pre-Congress webinars. Good evening and thank you for joining us. My name is Silvia Casas, Medical Affairs Director at CareDx. It's a great pleasure to moderate today's session, Redefining Transplantation with Non-Invasive Allograft Surveillance. It's time to adopt innovation solutions and improvements of a standard of care to positively impact patients' outcome. From today's excellent speaker panel, we will be hearing the later review about donor-derived cell-free DNA, the biomarker that has changed the way transplant physicians monitor and diagnose rejection. Kind reminder, please, to use the Q&A function below if you wish to submit any question to the panelists. And our first speaker is Dr. Jeroen Voorhoeve, medical doctor at the Department of Nephrology and Transplantation of Erasmus Medical Center in Rotterdam, the Netherlands. Dr. Voorhoeve focuses his research on the clinical value of minimally invasive biomarkers for the detection of acute allograft rejection in kidney transplant recipients. He investigates potential biomarkers such as donor-derived cell-free DNA and circulating nucleosomes. Dr. Voorhoeve's presentation today is on recent advancements in cell-free DNA biomarker testing for transplant surveillance. Welcome, Dr. Voorhoeve, and we are all looking forward to hear from you.
So thank you for the invitation to speak here about cell-free DNA, the journey so far. So what is cell-free DNA? Cell-free DNA is double-stranded DNA fragments which are quite short, between 160 and 200 base pairs mainly. Cell-free DNA is released in blood and other biofluids during cell death, such as apoptosis, necrosis, and also by active secretion. Cell-free DNA is mainly derived from apoptotic circulating white blood cells, the hematopoietic cells, and it is cleared by the liver, the kidney, and degraded by enzymes such as DNases and nucleases. The half-life time of cell-free DNA is quite short, between 50 minutes and 2.5 hours, and differences in cell-free DNA concentrations has already been observed between healthy individuals and patients. And currently, cell-free DNA has already been applied as a biomarker in the clinic, for example, for prenatal testing and in the oncology. And it is also a promising biomarker in transplantation. Here, I show you in 1948, which was the year where cell-free DNA for the first time was detected. It was done by a study by Mendel and Meta in 1948 that showed that cell-free DNA is present in blood of individuals. And this was even before the structure of DNA was elucidated. I show you an overview of the rapid advancements of cell-free DNA in prenatal testing and in the oncology in this figure. In 1948, cell-free DNA was detected for the first time, and since then, many big steps have been made, especially in 2011, for example, for prenatal testing, and in 1997. So in 1997, it became possible to identify fetal cell-free DNA in pregnant women. And in 2011, for the first time, it was possible to detect, or there was a commercial prenatal diagnostic test for detecting non-invasive prenatal tests to detect congenital abnormalities, which reduced the amount of amniocentesis and chorionic villus sampling in pregnant women. And in the oncology, most of you know that in the oncology, cancer is driven by mutations which are present in DNA. And these cells, these cancer cells, shed also cell-free DNA in the circulation with this certain mutation. And these mutations can be detected in the circulation, and based on that, patients can be screened for a certain cancer type or can be monitored. For example, once patients with a certain cancer type are treated with anti-cancer therapy to see whether there is a response on therapy based on the presence of a certain mutation in the circulation. And as I told you, cell-free DNA is also a potential biomarker in transplantation. The reason for that is that the current diagnostic tools to monitor or evaluate the immune response to a transplant are limiting. We are using conventional biomarkers, but we know that these biomarkers are limited in terms of sensitivity and specificity, for example, for allograft rejection. And that's also the reason why we still need to perform a biopsy, which is the gold standard for many solid organ transplants. But we know that these biopsies are invasive, can put the patient at risk for certain complications. It is costly, and the diagnosis can be missed as a result of sampling error. And next to that, the pathologist, the diagnosis can also differ depending on the pathologist that examines a biopsy. So there is an unmet need for new biomarkers for serial minimally invasive monitoring of the allograft. And these biomarkers should have a short turnaround time, should be implemented easily in the clinic, and have affordable costs. And there's the place for cell-free DNA or donor-derived cell-free DNA in transplantation. So how can donor-derived cell-free DNA be detected? Donor-derived cell-free DNA can be detected based on chimerism. So we know that donor cells, except of identical twins, are genetically distinct from the recipient. And based on that, donor-derived cell-free DNA can specifically be detected. And the hypothesis is that in a stable situation, for example, in the case of a kidney transplant, that the release of cell-free DNA from the allograft, donor-derived cell-free DNA, that is low, but at times of allograft injury, for example, at times of allograft rejection, that at that moment, there is an increased release of cell-free DNA from the transplant, which can be detected. So in 1948, cell-free DNA was for the first time detected, but in 1998, so 50 years later, Lowe et al. For the first time detected donor-derived cell-free DNA in this study. So Lowe et al. Showed that cell-free DNA from the transplant could be detected in kidney and liver transplant recipients. So this was actually the first study in cell-free DNA research and transplantation. There are several possibilities to distinguish the donor from the recipient, and Lowe et al. Used sex-specific chromosome differences in 1998 to detect the donor-derived cell-free DNA, so sequences on chromosome Y. But the limitation of this method is that it is only applicable in female recipients who received an allograft from a male donor, so in more or less 25% of the cases. And later, also other possibilities were used to distinguish the donor from the recipient, for example, by measuring human leukocyte antigen HLA sequences. But also with this method, it is not always possible to find differences in HLA, because we all know that in transplantation, the recipient and donors are matched based on HLA. So it can be difficult to find other HLA sequences. Another and mostly used ways to discriminate the donor from the recipient is by using single-nucleotide polymorphisms, SNPs, or insertion and deletion polymorphisms, indels. And SNPs are differences of in the genome of just one base pair, whereas indels are differences in more than one base pair. And nowadays, single nucleotide polymorphisms are the mostly used way to distinguish the donor from the recipient. And that is also shown in this overview, where cell-free DNA was detected in kidney transplant recipients. And then you can clearly see that in most of these studies that SNPs were used to discriminate the donor from the recipient, a SNP panel. In 2011, Snyder et al. Showed in a study that SNPs can be used to detect donor-derived cell-free DNA, which was also called genome transplant dynamics. And detection of SNPs was also based on individual genomic distinction, of course. What they did was they both genotyped the donor and the recipient and the panel of SNPs that was used to find the donor-specific SNPs contained SNPs with a certain minor allele frequency. So that means that were SNPs with a certain variation in the population to guarantee that donor-specific SNPs could be detected to eventually detect donor-derived cell-free DNA. There are several quantification approaches nowadays due to, of course, the improvements in molecular diagnostics. So in the beginning, especially the quantitative PCR was used to quantify donor-derived cell-free DNA. But since 10 years, also a droplet digital PCR, dd-PCR, is used, and of course, next generation sequencing since a few years. And in the beginning, detection of donor-derived cell-free DNA was limited because the sex-specific chromosomes that were used to detect the donor or HLA sequences. But later on, it became possible to detect donor-derived cell-free DNA in more patients, and first by both genotyping the donor and the recipient. But a disadvantage of that is, of course, that it is not always possible to collect donor-derived cell-free DNA or donor DNA, especially when, for example, a patient was transplanted in the past. So nowadays, it's possible to detect donor-derived cell-free DNA without the need for genotyping the donor and the recipient. So that's an enormous improvement, of course. Yeah, the two quantification methods that are currently used are the dd-PCR and NGS. So what is the dd-PCR? Droplet digital PCR is a PCR with a very high sensitive way to relatively and absolutely quantify donor-derived cell-free DNA. And here I show you how that happens. So compared to the quantitative PCR, the dd-PCR partitions the sample in thousands of droplets, and then in each droplet a PCR will be run. And after these PCR, in the droplets, the amount of donor-derived cell-free DNA can be detected, or cell-free DNA from the recipient, or no cell-free DNA. So in each droplet, cell-free DNA can be quantified. And based on that, cell-free DNA can be expressed as either a percentage, so meaning a percentage of total amount of cell-free DNA, or as a concentration, and both have strength and weakness. Another way to quantify donor-derived cell-free DNA is, of course, with the NGS, as I told to you. And with the NGS, cell-free DNA is amplified using a multiplex PCR with a certain amount of SNPs. And after that, the sample is sequenced with a next-generation sequencing. And after that, the percentage of donor-derived cell-free DNA can be calculated with a certain algorithm. And both detection or quantification methods have a similar analytical validity, which was shown in this figure in a publication of previous year. So they both found lower limits of quantification of 0.15 to 0.20%. So there are several challenges in the cell-free DNA nowadays. For example, how to express cell-free DNA. You can both express it as a relative amount, so as a percentage, or as an absolute amount in concentration. And a benefit of using a percentage is that that it corrects for pre-analytical variabilities. For example, DNA extraction efficiency and degradation rate. For example, there can be differences between the DNA extraction efficiency between samples, but by using the percentage, it will be corrected for that. And another possibility is, of course, express it as a concentration. And a benefit of that is, of course, that a concentration is not affected by changes in the amount of recipient cell-free DNA, because we know that, for example, cell-free DNA from the recipient differs over time depending on, for example, whether a patient has an infection or exercise, workout, medication. And we also know that by using the PCR-based methods, that the PCR efficiency is affected by the amplicon length and the donor-derived cell-free DNA length, and that could give an underestimation of donor-derived cell-free DNA. So it's also very important to take that into consideration. Thank you for listening to this presentation, and I'm very happy to answer some questions later on during this webinar.
Thank you, Dr. Verhoef, for such interesting presentation from laboratory and method perspective. It helps to put in perspective for how long medicine knew about the presence of circulating cell-free DNA in bloody fluids, and that thanks to the modern genetic medicine, we can now accurately measure and really use it for medical applications such as transplantation. I encourage all of you attending today to please ask questions through the Q&A function so that we can take it, all of them at the end of the session. And right now, continuing on this interesting topic about applications on donor-derived cell-free DNA for transplantation, I would like to introduce our next speaker, Professor Micha Arnold, head of the Center of Kidney Transplantation and Clinical Transplant Coordinator and Director of the Nephrology Department at the University Medical Center in Ljubljana, Slovenia. Professor Micha Arnold does research in kidney transplant medicine and nephrology. He has a large professional affiliations nationally and internationally, being a very active member. He's going to introduce us the donor-derived cell-free DNA for the detection of kidney allograft rejection. Welcome, Professor Arnold, whenever you are ready.
Thank you for the kind introduction. Dear colleagues, ladies and gentlemen, dear friends, first of all, of course, I would like to thank the ESOT and of course also the CareDx for their kind support of this, I believe, very interesting webinar. Nevertheless, I would like to start this presentation with challenges in kidney transplant medicine that we face nowadays. And I would like to share with you a clinical case which shows how monitoring of our transplanted patients and their grafts can be actually suboptimal and sometimes also quite inaccurate. So this is a recipient approximately 2 weeks post-deceased donor kidney transplantation and delay graft function. And according to our center protocol, we perform a surveillance biopsy specifically to include associated rejection. And indeed, the pathology report was suspicious for early acute T-cell rejection, and this patient received pooled steroids. However, he then developed post-transplant diabetes, and we know that this adverse event is actually associated with inferior long-term transplant outcomes. However, over the last year or even longer, we are also sending a piece of our biopsy specimens to the Phil Halloran's lab in Edmonton, Canada, for the so-called molecular microscope diagnostic report. And this molecular transcriptome analysis actually could not show active antibody-mediated or T-cell rejection. And even furthermore, we send out our blood sample for donor-derived cell-free DNA level. And at this low value and at this 0.5 threshold value, we know that this value quite accurately identifies immune quiescence, so that this patient does not have active rejection with quite high negative predictive value over 70%. So with this more precise information on board, we probably would not treat these patients with additional immunosuppression, and therefore this patient might not develop post-transplant diabetes. We know that nowadays the rejection is still a leading cause of kidney allograft failure. Specifically, the most common type of rejection and phenotype of rejection is antibody-mediated rejection. usually associated with under immunosuppression related to most commonly patient non-adherence, or sometimes physician-related due to immunosuppression adverse effects. But what are the current critical unmet needs associated with kidney graft rejection? First of all, we have the issue with precision of diagnostic approaches, as I already showed you in this clinical case report. Then we are facing the problem with the efficacy of our therapeutic options, specifically when trying to treat chronic antibody-mediated rejection. And of course, we lack several kinds of mainly non-invasive biomarkers to refine our diagnostic, prognostic, and predictive information for our transplant recipients and their allografts. So here, how we usually use and the options that we have to survey our patients' kidney allografts. So this is the serum creatinine, the GFR, and proteinuria. And we know that these biomarkers are more or less non-specific, and that final diagnosis usually requires an invasive kidney biopsy. And whether for cause or for surveillance, this usually presents difficult logistics, of course, risk for the patients, and also high costs. So these shortcomings have stimulated research in several kinds of novel, invasive and non-invasive biomarkers, whether in the blood, urine, and graft tissue, to detect different transplant pathologies, including allograft rejection. And why we need them specifically, it is well established that in patients, even with stable kidney function, subclinical acute rejection can be detected in up to 25% of protocol biopsies that we perform for our patients in the first year following kidney transplantation. And moreover, we know that these early inflammatory events and subclinical rejection are associated with worse outcomes in the long term. Therefore, we definitely, there is a clear need for the development of several kinds of non-invasive biomarkers to detect these early inflammatory events, even for patients with stable graft function, specifically to prevent ongoing chronic injury and parenchymal fibrosis. And we know that this is usually associated with de novo DSA formation, chronic ABMR, and premature graft failure and loss. And the literature is actually full of innovative approaches. And there are now several biomarker development studies correlating different genomic, transcriptomic, as well as proteomic information with clinical and histological phenotypes of rejection. However, there are still critical challenges that we faced. More or less for the most of these biomarkers, the field is still trapped in the discovery phase. And furthermore, most of these are unfortunately not available for routine everyday clinical use. However, this is not true, as we already heard about the donor-derived cell-free DNA, a novel biomarker. And you've heard a lot about the analytical validity of this biomarker in the previous talk. And here in the following presentation, I would like to show you some more information on the clinical validity and utility of this novel molecular biomarker. And this is the landmark DARK study. And this study showed that donor-derived cell-free DNA actually accurately discriminates between active rejection versus no active rejection, and it definitely outperforms serum creatinine. And in this study, the levels of donor-derived cell-free DNA were significantly higher in patients with antibody-mediated rejection as compared with patients with T-cell rejection. And specifically at this proposed 1% threshold, this biomarker has a good utility in recognizing specifically endothelial cell injury and is more sensitive to a higher grade rejection, specifically vascular T-cell rejection or microvascular inflammation associated with antibody-mediated rejection. Another more recent, the so-called RADAR study published last year in the AGT showed that probably this 1% cutoff level is quite insensitive in identifying early subclinical T-cell rejection, specifically low-grade BAM41A or borderline rejection. And this is the violin plot showing different cutoff values for the donor-derived cell-free DNA. And actually the largest demarcation in this particular study sample was observed at the lower threshold value of 0.5% of donor-derived cell-free DNA. And actually at this lower threshold, we might distinguish even between lower grade T-cell rejection and no rejection findings. And what is even more important is that the elevated levels of this donor-derived cell-free DNA, about this cutoff value of 0.5%, actually predicted adverse follow-up outcomes between 3 and 6 months after the diagnosis of rejection, and meaning that a significant greater decline in estimated GFR and greater incidences of de novo DSA occurrence or recurrence rejection episodes. Meaning that this novel biomarker is not only a diagnostic, but also a predictive biomarkers for inferior outcomes after active rejection. Then another study, which is actually a retrospective review of the DART cohort, asked a question: can we use this donor-derived cell-free DNA as a biomarker to follow the success of treatment for rejection? And this study actually showed that persistently elevated cell-free DNA levels could indicate incomplete recovery of rejection episodes. And this was specifically true for patients with antibody-mediated rejection. And that in this case, we may need closer monitoring for our patients, and perhaps these patients need additional treatment of rejection to improve the further prognosis. And then finally, we come to the largest study so far, the so-called the Admiral study, which is a multi-center prospective studying kidney transplant patients undergoing surveillance with donor-derived cell-free DNA. And the first results were published in this year ATC Congress in almost 200 patients with more than 200 for course and surveillance biopsies. And the results of this Admiral study actually independently validate the results of the DART study and the performance of this biomarker in testing and for the detection of both clinically suspected and also subclinical rejection. And this AlloSure testing actually has utility in detecting clinical and subclinical T-cell rejection, antibody-mediated rejection, and differentiating versus no rejection, of course, with different patterns of elevation of this AlloSure test for different rejection phenotype versus no rejection phenotype. And similarly to previous Radar study, greater variation, and specifically an increase in these donor-derived cell-free DNA levels over time, are associated with greater risk for follow-up allograft injury, and greater levels of this donor-derived cell-free DNA was also appeared to predict de novo DSA formation and then follow-up antibody-mediated rejection. So what about combining different biomarkers? Can we do better with that? So this is the so-called trifecta study, the international prospective multi-center study trying to study the relationship between donor-derived cell-free DNA at the time of indication biopsy to conventional and molecular features in the biopsy and to the central anti-HLA donor-specific antibody assessment in One Lambda lab in California, with the main study aim to calibrate specifically the circulating donor-derived cell-free DNA level at the time of indication biopsy against the molecular phenotype of the biopsy. And early results, again presented at the ATC of this year, demonstrate that there is a strong relationship between this percentage of donor-derived cell-free DNA and allograft rejection, particularly with the molecular antibody-mediated rejection classifiers. And this relationship were actually stronger for the molecular than for conventional histologic diagnosis. And another example of combining different biomarkers is to combine information with donor-derived cell-free DNA testing and gene expression profile in the peripheral immune cells. And this study show how AlloSure and AlloMap testing actually had a higher positive predictive value and actually had better performance characteristics in identifying patients with de novo DSA who actually at the same time also have active antibody-mediated rejection when compared only when we perform the surveillance DSA strategy. So by combining different biomarkers, we might get better information and we can decide which patients to biopsy and not to discover active rejection. And then going to another biomarker, which we also think is very interesting, and our center is also performing research on these very interesting novel biomarkers, also including cell-free and bound DNA, and these are the so-called urinary extracellular vesicles. And we know that urine is actually an excellent source of biomarkers because it is a direct product of the kidneys and also the transplanted kidneys. And urinary extracellular vesicles are actually involved in internephron communicating and may carry different pathophysiology signals along the kidney and are then spilled in the urine. And in this context, the urinary extracellular vesicles and their cargo, of course, including the DNA and extracellular vesicle bound DNA, may enable direct, continuous and non-invasive detection of kidney allograft injury, including rejection. And actually over the last year, in collaboration with our National Institute of Biology and Institute of Biochemistry in our medical faculty, we were able to successfully isolate these pure extracellular vesicles from urine and try to characterize their content, including DNA, using different molecular technologies, including transmission electron microscopy, nanoparticle tracking analysis, digital PCR, and Western blot. And these are some preliminary results in the first 41 patients with indication and surveillance allograft biopsy. And this study showed that cell-free and extracellular vesicle bound DNA were actually significantly higher in the urine of patients in whom biopsy showed rejection episodes as compared to unspecific inflammatory findings such as IFTA or normal histology in this indication and surveillance allograft biopsy. So this is a promising approach. We still need to do some further work and the manuscript is in preparation. So for the end, what is our approach in our transplant centers on biomarkers and how to refine our kidney transplant medicine for our patients? So this is the so-called biomarker guided care for our transplanted patients and we use several kinds of clinical as well as molecular biomarkers to detect over-immunosuppression, under-immunosuppression, allograft injury, including invasive ones with MMDX, of course with the main aim to optimize the immunosuppression, to improve graft function and detect subclinical injury, specifically rejection, of course at the end of the day to decrease the ongoing chronic injury and of course to decrease the adverse events for our transplant recipients. We have to be aware at the end, of course, that many steps are actually in between this potential biomarker as a surrogate for a true clinical endpoints, and that of course we need clinical prospective trials to show that these biomarkers actually are validated surrogate biomarkers for hard endpoints. Unfortunately, there are no shortcuts. A correlate does not a surrogate make. And we believe in this integrative assessment of the immunosuppression and allograft injury, specifically subclinical injury for our patients. And we need to combine the clinical and epidemiology data, the histopathology information, the immunogenetics, and of course, we have to go with the transcriptomic analysis using these novel biomarkers, including donor-derived cell-free DNA, of course, to refine and to improve our preciseness for the diagnosis of allograft injury as early as possible for our patients. Of course, then to prescribe the appropriate treatment at right time as early as possible. And of course, with the main aim to improve our long-term prognosis for our transplanted recipients. I would like to end with that and would like to thank you for your presentation. And of course, we'll be happy to answer any questions at the end of this webinar. Thanks.
Congratulations, Professor Arnold. Very inspirational talk, which illustrates that we may be near to change the paradigm of care in renal transplantation. We look forward for an active discussion at the end of this session with the attendees. And the unmet needs in renal transplant have been excellent laid out. And it's important as well to underline that the donor-derived cell-free DNA can be used for surveillance as multi-organ. Like in lung, where the need for novel non-invasive biomarkers is such of urgency. So the next talk will be focused on a lung and donor-derived cell-free DNA, and it's a pleasure to introduce you Dr. Andrea Zayakova. Dr. Zayakova is consultant pneumologist and clinical researcher, currently working at the lung transplant program at Motel Hospital in Prague, Czech Republic. Her presentation is titled Donor-derived cell-free DNA in Lung Transplantation, a Game of Changer. Will walk us through these important features of donor-derived cell-free DNA in the very vulnerable recipient patients. Andrea, please, we are looking forward for your presentation. Thank you so much.
Thank you, Sylvia, for a very kind intro. Hello, everyone, dear colleagues, dear friends. I'd like to start with my presentation regarding cell-free DNA. Oops, I'm sorry. Now it should work, okay. The title of my presentation is Donor-derived cell-free DNA in lung transplantation, a game changer. My disclosures. When it comes to the lung transplantation, of all major organ transplantation, the lung transplant recipients have the worst long-term survival. The median overall survival is about 6 years. The major cause of morbidity and mortality in the long-term period is chronic lung allograft dysfunction. When it comes to the surveillance of the patients, we may use a few tools. Regarding pulmonary function tests, spirometry and body plethysmography are available. We've got X-rays and CAT scans, and also we've got transbronchial biopsy, which are performed even for a cause or just for a casual surveillance. Unfortunately, all of these tools are relatively clinically insensitive, and sometimes we miss what we are looking for. So that's why we are in need of a new biomarker. Here comes the cell-free DNA. Circulating cell-free DNA are short DNA fragments produced from nuclear or mitochondrial cells by the cell, which comes to the apoptosis or necrosis, or sometimes they're even actively secreted by the cell. The DNA is not circulating by its own, but it's bound to the histones, and so nucleosomes are created. However, the majority of the cell-free DNA is found in the form of extracellular vesicles, or sometimes even in the form of nets. But when it comes to the transplantation, the thing we are interested in is donor-derived cell-free DNA. As you may see, when there's an injury to the graft, the cells are damaged and the cell-free DNA is released. When we've got allograft injury, we may detect donor-derived cell-free DNA in the blood of recipient. The higher amount of donor-derived cell-free DNA, the greater the injury to the graft is. There is a possibility to detect cell-free DNA in all body fluids, but in lung transplantation, we predominantly use blood. But there are also very few indications for the cell-free DNA analysis in the bowel fluid. Also, cell-free DNA is a very sensitive tool, and we are able to detect graft injury, which are undetectable by classical clinical tools. So there is no cutoff when it comes to the levels of the cell-free DNA, no absolute cutoff. As we might see here, every patient has its own average level of the cell-free DNA. According to the average level, which is made in the early post-transplant period of 3 months, we may divide patients into the groups of the upper, middle, and low average level of DNA. Patients within the upper tertile have the worst long-term survival, as we may see, and also the patients with the low tertile have the best outcomes. Also, the average levels of the cell-free DNA correlates with the graft function, and we may see that the patients with the lowest level have the best FEV1 results. How the average levels are determined, it's still unknown, but we know that the well-known risk factors such as primary graft dysfunction, unfavorable match in CMV, older age of recipients, or a smoking history are more prevalent in a group of the higher average level of cell-free DNA. When it comes to the acute cellular rejection in our lung histology is the golden standard, and the only way how we can obtain it is by biopsy. As you may see depicted here, even when we use cryobiopsy, which is more risky than a classical forceps one, we are not always able to obtain all the tissue we are interested in, for example, bronchi. But here we may see that the cell-free DNA levels might be very helpful because dd-cfDNA levels are significantly higher in patients with acute cellular rejection than in patients with a normal graft function. The sensitivity of this test for the acute cellular rejection is 86%. And also there is a strong negative predictive value. However, the most challenging diagnosis in lung transplantation is antibody-mediated rejection. To obtain the diagnosis, there is a condition of the graft dysfunction in combination of one of the following factors. So other causes excluded, donor-specific antibody presence, lung histology verification, or even positive C4D staining in the lung biopsy. According to the combination of the mentioned factors, we may state that the antibody-mediated rejection is possible, probable, or definite. There is, for a long time, a hypothesis that antibody-mediated rejection is connected with the higher graft dysfunction and higher alteration of the tissue than acute cellular rejection. Here we may say that at the time of clinical presentation, patients with antibody-mediated rejection present with a higher drop in FEV1 comparing to the acute cellular rejection. This is very well correlated with the levels of the dd-cfDNA. We may say that at the time of clinical diagnosis of antibody-mediated rejection, levels of the cell-free DNA are significantly higher than in the patients with acute cellular rejection. Also, very interesting fact is that even when we are able to obtain a histopathological proof of antibody-mediated rejection, which is not so common, we may say that the patients with a positive histopathological findings have higher levels of dd-cfDNA than the patients without histological correlate. Very interesting thing is the interpretation of the assay. As we all know, the interpretation of the assay might get very tricky, but when we divide patients according to the maximum MFI of their DSA to the group of low and high with a cutoff of 10,000 MFI, we may see that the patients with a low DSA group have lower levels of dd-cfDNA comparing to the high DSA group. Also, there is a difference in intra-individual levels of the dd-cfDNA, which is very strongly binded to the MFI. What's very interesting is that dd-cfDNA is able to detect subclinical rejection, which might be amazingly helpful, especially in the antibody-mediated rejection. In this graph, we may see that there is a first transient rise in the level of the dd-cfDNA several months before diagnosis. And it's mainly represented by acute cellular rejection or infection or any different kind of pathology. Then there is a second change, the sustained, the one, and we here may say that the levels of the cell-free DNA are significantly higher in the first month before the diagnosis of antibody-mediated rejection performed by clinicians. What's also very interesting to see is that the levels of the DSA MFIs are correlating with the levels of the dd-cfDNA levels. The leading cause of morbidity and mortality after lung transplantation is chronic lung allograft dysfunction. The diagnosis itself is made by graft dysfunction criteria and radiological findings. Nowadays, we are able to determine 4 types of chronic lung allograft rejection. The etiology of clot is unknown, but we know that there are a few risk factors. When we are having a look at the levels of dd-cfDNA in the clot patients, we may see that the patients with a higher average level of dd-cfDNA have a significantly lower clot-free survival period in comparison to the patients with a lower low, and middle cell-free DNA average levels. Also, one of the known risk factors for the development of clot is primary graft dysfunction. But not every primary graft dysfunction leads to the clot. And here may be the explanation why. As we see in this graph, patients with primary graft dysfunction who developed subsequently clot have higher levels of dd-cfDNA in the time of diagnosis than the patients with primary graft dysfunction who are clot-free. Also, there is a strong relationship between primary graft positive patients who subsequently develop clot and primary graft dysfunction negative patients who do not develop clot. But when it comes to the differentiation between subtypes of chronic lung allograft dysfunction, blood here is for now not useful. So we may analyze bowel fluids of the clot patients. When you have a look on this graph, you may see that the amount of cell-free DNA in the bowel of both patients is significantly higher than in the RAS patients. However, when we compare both BOS and RAS cell-free DNA levels in the bowel, we may see that they are higher than in the patients with a normal lung function. Also, when we analyze bowel fluid of the patients with clot, we may see that the higher the cell-free DNA level is, the worse is survival probability. So for now, it seems that the cell-free DNA is an emerging marker, but what we are not able to detect now is gastroesophageal reflux and also microaspiration, which is very well known to cause different problems in the lung, acute rejection, chronic rejection. We are also not able to differentiate between the subtypes of clot by peripheral blood. Also, there are very few data supporting the differentiation between infection and colonization in lung transplantation. And also, there are, for now, some presentations that have been published in the International Society of Heart and Lung Transplantation Congress that there may be a possibility to differentiate in lung transplantation between patients who are responding to the therapy and from the patients who are not responding to the therapy. Thank you all for your attention, and I'm looking forward to the discussion.
Thank you, Andrea, and thank you to all participants and the speakers for this very interesting session. I hope the attendees enjoyed hearing all the experiences and real how this novel biomarker for non-invasive monitoring of transplant surveillance could be incorporated into clinical routine and improve really how we decide and monitor patients. So now it's time to open for Q&A. We have almost 10 minutes to be able to answer any questions that attendees have submitted to the Q&A, where Andrea was discussing and finishing her presentation. I was also adding some comments to the chat. Let's review if there is any further questions, and I will bring any of those to you. Just a minute. So basically, we had several questions, and probably this is for Jeroen and Professor Arnold about the utility of donor-derived cell-free DNA in renal transplantation and how the biomarker could be useful to discriminate between harmful and non-harmful DSA. So probably all of you have been in a situation where the patient has positivity of this DSA over time, and how this biomarker, in your opinion, could be useful in this setting.
So shall I start?
Please.
Yes. So this is actually a very important question, and we face with this problem actually in everyday clinical practice. We also in our center usually use this de novo DSA surveillance, and we cannot always be sure whether this de novo DSA, we cannot only rely on these MFI values because we know this is not the absolute quantitative value, and we cannot be always sure, specifically in clinically stable patients, whether these are harmful to the graft or not. And as I've shown you in my presentation, and there is also another study from Stan Jordan from California, showing that actually when you add the AlloSure test, the donor-derived cell-free DNA, when you had an elevated level or percentage, specifically about 1%, and I think they were actually a bit higher, closer maybe to 2%, then actually this is a sign of ongoing microvascular injury, of ongoing inflammation. And these are probably the patients that we need to do a biopsy. While on the other hand, low values, specifically below 0.5% and de novo DSA, these allografts were quite quiescent, and I think we have to monitor them in the follow-up. And probably perhaps within the next 3 to 6 months, we have to repeat probably the MFI levels and maybe perhaps to do another AlloSure testing, and then decide whether these patients need a biopsy, because when serum creatinine or proteinuria goes up, then we are too late. Then the injury is already there. Then will be some scarring. There will be duplication of the basal membrane, and then, of course, the injury of the graft is ongoing, and it definitely goes toward kidney dysfunction and over several years to graft failure and loss. It has been known that clinically, de novo DSA are associated with half-life about 3.5 years and subclinical about 8 to 10 years. And of course, we don't know at this time whether these are deleterious or not. And when adding I've shown you the additional testing to refine this information, then we actually can decide what should we do at this short point. Should we just follow the patient, or do we need some treatment or follow-up, and how best to care for this patient? This would be my answer.
Thank you. Thank you. Jeroen, would you like to add any comments to make a discussion on the question?
Yes, I think that it's very important to use additional tests as cell-free DNA also in these cases. I think that cell-free DNA can be really helpful also to rule out problems of the kidney, for example. So if it's below a certain threshold, also with de novo DSAs, then that there's no indication to do an additional biopsy. But then you need to monitor these patients and to measure cell-free DNA at later time points to see what happens, and if there's an indication or when there's an increase above this threshold with a de novo DSA, then perform a biopsy. But in the to first to reduce, of course, the amount of biopsies with using cell-free DNA instead of doing more biopsies.
Correct. And maybe I can bring the experience from United States, and there this biomarker is using more than 80% of the renal transplant units. On surveillance, this is a schedule of like 7 time points during the first year after transplant, and quarterly after the second, and beyond years after transplant. And basically, this biomarker helps either at surveillance, right? So we can imagine monitor all the patients in surveillance, as well as at high-risk patients, right? So both combinations is suitable for those patients and this biomarker. And basically, one maybe would have shown choose from which type of patients to start. Probably the high-risk patient with DSA positivity would be a very interesting subset of patients to start. I may bring one additional question regarding the presentation from Professor Arnold. There is Karim Boer asking if it's known which proportion of the donor-derived cell-free DNA end up with E vesicles compared to the free cell-free DNA coupled into the nucleosomes, and if this donor-derived cell-free DNA in the vesicles protect from the degradation.
Actually, this is a difficult question. I can start with the last part of the question. So this was our hypothesis, that within the extracellular vesicles, this DNA is actually more preserved and more reluctant to degradation. And actually, what we are trying to see the differences between, that's why we are actually exploring and investigating the cell-free DNA and the nucleosome-based and bound DNA. But I've shown you just the preliminary results. Unfortunately, I cannot answer to this question because we still have to stratify these patients on different kind of rejection and different injury phenotypes. We just can say that cell-free DNA and also extracellular vesicle-bound DNA were significantly high in rejecting patients versus other injury phenotype or normal findings. Whether there is a difference, that's what we were expecting. That's why we are also investigating both of them. I unfortunately cannot answer that, and I don't have in mind other study actually showing that. There was, published one study on extracellular vesicles in the adjacent this year, but they were not studying cell-free DNA, but other markers, specifically microRNA and mRNA in these vesicles. And this was published in JASN this year. I think just a Harvard study in about 150 patients. And I think this biomarker shows great promise, and we'll see whether there is a difference. And I think this is an important question. That's why we are also exploring this.
Fantastic. We will look for this data published. And I would like to come back to one first question that was put on the chat that I would like to bring to the panelists, is about the half-life of the biomarker, which is about 30 minutes. And there were a question about if this means that due to the short life, we cannot store cell-free DNA for a prolonged time. I think that maybe the attendee got confused about the short life and the stability in vitro. But I would like the panelists to discuss on that more like technical question.
Yes, thank you. Yeah, sample stability is a very important pre-analytical variable, of course. There are two important things with cell-free DNA that is collected. Of course, it has a short half-life time. And once it's collected, you need to prevent that, especially the white blood cells become apoptotic, which can lead to an additional release of cell-free DNA from the recipient, because then you get an underestimation of the total of donor-derived cell-free DNA values. We do know that, for example, by collecting blood with EDTA tubes, that cell-free DNA can be stored in these tubes for a few hours, but then processing is necessary. But you can prolong or you can stabilize these samples for a longer time, for up to 1 week, for example, if you use different tubes, cell-safe tubes. And if you, for example, want to ship samples to another place to measure a donor-derived cell-free DNA, then these tubes are very important to use, of course. So I think that we can store it for a longer time, but you need specific tubes to store cell-free DNA, of course, to guarantee the stability.
Right, and this is basically, how the biomarker has been quite successful to be adopted in the United States, where the blood samples collected in the specific matrix cannot be EDTA tubes. It's a specific matrix to collect the blood. But then once the blood is in these specific tubes, it's stable for 7 days at room temperature. So quite easy to distribute it around, right? So it guarantees that what we measure in the recipient blood is actually the picture of the donor-derived cell-free DNA was circulating, in the body, so that to measure the injury, the proportion of injury at that specific moment. I don't know if any of the panelists would like to use the last minute, coming back to this dynamic of the biomarker, right? Maybe discussing on the potential application for follow-up rejection treatment and how the dynamics and the slopes of the biomarker levels could be useful to bring information to the physicians.
I believe this is again a very important issue. We know that it is difficult to perform a rebiopsy and rebiopsy after a biopsy in this patient, and it's then difficult to assess what is the outcome of rejection and treating the rejection episodes, because we cannot perform, and we even don't know at what time point exactly to perform a rebiopsy after the treatment of rejection. So I think this is again the added value of another biomarker to select the appropriate time to do a biopsy when something we know it's not right, whether the, let's say, cell-free DNA is staying high although we are treating rejection. If it goes down and stays there probably is no need. It has been shown that if it goes to, let's say, the percentage of around 0.2, we know that the negative predictive value for immune quiescence is more than 90%. So we can be quite sure and we can reassure the patient that everything is okay. But when we see that, like a creeping creatinine, but then it's too late. When we see a creeping cell-free DNA level, then we might think that we should do a rebiopsy at that point in time and not to wait for a creeping creatinine because there is too late, or a proteinuria to evolve. So this is again how another biomarker can add more precise information when to do a biopsy, and then of course also how to and when to intervene with additional immunosuppression, and how to treat our patients and when to treat our patients. Or should these patients be monitored more often, more frequently, or if everything goes down and there is a high probability of immune quiescence, maybe we can postpone this measurement, let's say, for 2 or 3 months. This is the information that we should combine. But of course, the preclinical, I think, the clinical information combining with different sets of markers, also clinical and molecular, I think solves all this puzzle. It is not just one biomarker, as I've shown, that you should rely on, but I think it's the whole information. What shows the biopsy, how the kidney function improved after what kind of rejection was that? Was that diagnosis refined with also the molecular phenotype, and does it show more or less injury? And then with all this information on board, we probably get better and more precise information what's going on with the patient and the kidney, and how we should follow this patient maybe more or less frequently, and does he need additional treatment, adjustment, immunosuppression, and so on. So I think it's difficult to answer in one sentence, but I think this is the right way, as I showed in my last slides. So we need to combine the information from different clinical and molecular biomarkers to refine our care for our patients.
Yeah, I just kind of agree with you. This multimodality, is the way to go. Unfortunately, we have arrived to the end of this session. Thank you very much, the speakers and the attendees joining us. I remind that next step is to vote on this poll. It will come to your screens about how you would find the webinar today. So please give us your feedback, because this will really help our colleagues at ESOT to keep improving and offer this excellent medical education for all the delegates. So there is several options. So extremely useful, fairly useful, not useful. And we will see the result. And oh, that's fantastic. So 45% extremely useful and 55% useful. So thank you very much for sharing your feedback. We hope that has been indeed interesting for you. I would like to remind everybody that the series of webinars continues at ESOT. So please visit the ESOT website for more information of the upcoming webinars. And from CareDx perspective, and together with ESOT, we hope to meet you, we hope in person in Milan soon, next August at the annual conference by ESOT. Thank you so much. Good evening to everyone, and I hope to see you soon. Bye-bye. Thank you.